Visual impairment assessment efficacy with ERG.
Good morning, everyone. My paper is on the topic Visual Impairment Assessment Efficacy with Electroretinogram in Children on Vigabatrin and Descriptive Study. So, Vigabatrin is an anti-epileptic drug mainly indicated in cases of refractory seizures in children, and a major ocular adverse effect is retinal toxicity, which is manifested as visual field loss and is estimated to have a prevalence of about 30 to 40%. But for most children on vigabatrin, this cannot be assessed due to their young age and neurodevelopmental delay. So we need a objective test for detection of the retinal toxicity. So vigabatrin actually acts at the presynaptic terminal by inhibiting the enzyme GABA transaminase and thereby increasing the concentration of this inhibitory neurotransmitter and producing an anti-epileptic effect. So our study is to analyze the efficacy of assessing retinal toxicity of vigabatrin by using electroretinogram in a group of children with epileptic disorders. So we did this study as a retrospective study at a tertiary eye care institute from the time period 2016 to 23, and we collected data from electronic medical records which included detailed clinical history, functional vision assessment, ocular alignment and movement, cycloplegic refraction, dilated fundus examination, and ERG recordings at baseline visits and every 3 monthly follow-up visits. So the thing is, normal vision or visual field assessment is not possible in cases of these children. So we performed a functional vision assessment. But this is not a reliable test in detecting toxicity because it depends upon the general status and cooperation of the patient. So electroretinogram was taken at the baseline visit and follow-up visit under oral sedation with the syrup pedicloral. And following the ISCV guideline, we recorded the ERGs in retiport scan. In Gansfield illumination and detailed thread electrodes were used. We recorded visual evoked potentials in cases only in indicated cases. So coming to the results, out of the total 20 subjects, which included 11 boys and 9 girls, the mean age of the study population was 5.4 years, and the majority of the study population was below the age of 3 years. Mean duration of therapy in our study population was 41 months, which was ranging from about 1 month to 9 years. Only 2 study subjects had a longer duration of therapy of more than 5 years. The major indication of the drug in our study population was West syndrome or infantile spasm, followed by hypoxic ischemic encephalopathy. And in the study group of infantile spasm, the etiology was mainly idiopathic, followed by tuberous sclerosis. So this is how the frequency distribution of functional vision assessment at the baseline visit went. And about 70% of the children had poor functional vision at the time of presentation, indicating a need for an objective assessment. And moreover, 2 children who developed vigabatrin toxicity actually showed improvement in functional vision assessment that can be probably due to better seizure control, establishing that it is an unreliable indicator for assessing vigabatrin toxicity. So this is a table which shows the absolute values of B wave and oscillatory potentials in the 7 patients who developed vigabatrin toxicity. So this is a serial ERG of a single patient who had vigabatrin toxicity. ERG waveforms are shown from the baseline at the top trace and the follow-up 3, 6 and 12 months of visit, which shows a gross reduction in the B wave amplitude. So this is a percentage reduction of the ERG amplitude from the baseline through the follow-up visits in all the 7 patients who developed vigabatrin retinal toxicity. This is a linear plot which shows reduction in the absolute value of the oscillatory potentials in the patients who developed toxicity. VEPs were recorded only in cases of suspected optic nerve dysfunction or optic nerve pallor, and we got 7 case subjects who had optic nerve pallor clinically, but the abnormal waveforms were present only in 3 of them. But there was no significant correlation between VEP and retinal toxicity. So coming to the discussion, the prevalence of vigabatrin-induced retinal toxicity in our study group was 35%, which is less than that of Westall et al. That was 21%, which is the largest cohort of children with infantile spasms investigated for vigabatrin-induced retinal toxicity, and it is compared to Magyar et al., which is a systematic review. Our study showed a percentage reduction of ranging from 55 to 83% in B wave amplitude, which was 37 to 52% in Westall et al. Reduction in the amplitude of this light-adapted 30 Hz flicker cone electroretinogram is associated with vigabatrin attributed field loss, so it provides an assessment of retinal damage. Oscillatory potential reduction with the vigabatrin treatment was also observed in our study. So there have been studies which shows male predilection in vigabatrin-induced retinal toxicity, but this was not observed in our study. Coming to the conclusion, vigabatrin has been known to cause retinal toxicity in long-term usage. Hence, assessment in pre-verbal population with a reliable investigative modality is of utmost importance. Our analysis indicates that ERG is an effective tool for monitoring vigabatrin-induced retinal damage in pre-verbal children. These are my references. Thank you.
So I have two comments. Very nice study, good thought. What's the mechanism of VGB causing a retinal toxicity? Which layer or where does it affect?
The exact mechanism has not been till date has been discovered, but they say that it is at the photoreceptor level and the bipolar cell level, the damage causing due to increased level of this inhibitory neurotransmitter probably.
So what's the limitation of using full field ERG as a marker for any of these toxicity? Can you think of a limitation of ERG as a tool?
So one, it is it's not available in every center.
No. So the limitation would be ERG generally is a summative response.
Okay.
And it tells you if larger area of the retina is affected.
Yes, sir.
If the toxicity is limited to macula, it may not reflect in full field ERG. Then you require a multifocal ERG
Yes, sir.
to reflect. Number one. Number two, please remember, though VP is described as an optic nerve function test, but actually the origin of the VEP is from the macula.
Yes.
So anything which can affect macula in a larger scale would be reflected in VEP as well,
Yes, sir.
right? But a very nice study.
What about cerebral visual impairment? Would that affect these tests?
These ERGs, ma'am, actually we are not taking the absolute value of the B wave amplitude, but we are comparing it with the baseline of that patient itself. So we are looking for a significant reduction in the B wave amplitude rather than the absolute value. There will be an reduction when we compare it with the normal population. Actually, there is reduction in B wave amplitude because these babies are mostly having neurodevelopmental delay. So the absolute value is not what we consider, but the reduction. We have the follow-up visits.
Further going to study, what happened to the patients though had toxicity?
So the thing is, we have not taken any fields to establish that the results we got with the ERG is comparable to what we expect to have. So the thing is, giving vigabatrin. So we advise the pediatric neurologist to stop the drug, but it is actually on their hand also because the baby may be only having controlled infantile spasm with this single drug. So it is sometimes they stop, but sometimes they continue at a lower dosages and they review again for repeat ERGs.
Good morning. My paper is on turbidity of cyst as a biomarker and association with systemic comorbidities in center involving diabetic macular edema. Diabetic macular edema is the most common cause of visual impairment in patients with diabetes mellitus, and it represents an accumulation of fluid within the central portion of the retina, which arises as a consequence of failure of blood-retinal barrier. These are the OCT patterns of diabetic macular edema. The first one is cystoid macular edema, second is spongiform edema, and third is the neurosensory detachment. Turbid cyst is defined as a cystoid spaces completely or partially filled with grayish, irregular, hyperreflective material without backshadowing in the OCT B-scan cross-sectional images. Our aim of the study, systemic correlations of center involving diabetic macular edema patients with turbid appearing cyst and with non-turbid cyst, and to evaluate the associated OCT characteristics in turbid appearing cysts like central foveal thickness, disorganization of inner retinal layers, and hyperreflective foci. Materials and methods, it was a cross-sectional study period from January 2022 to January 2023. 101 eyes of 70 patients with center involving diabetic macular edema is selected and is divided into two groups. Group 1 containing turbid cyst and group 2 with non-turbid cyst. We included patients who were diagnosed with center involving diabetic macular edema, and we excluded vitreomacular interface abnormalities, glaucoma, other retinal or optic nerve pathologies, previous history of treatment for diabetic macular edema. And baseline data collection include gender, type of diabetes, duration of diabetes, severity, other comorbidities, and ophthalmological examination like best corrected visual acuity, fundus examination, and spectral domain OCT. And these are the OCT parameters. Central foveal thickness is a vertical distance from internal limiting membrane to outer border of the RP using the caliper tool in OCT Heidelberg. And hyperreflective foci is defined as the presence of small hyperreflective particles scattered throughout the retinal layers due to accumulation of proteinaceous material or activated microglial cells. And disorganization of inner retinal layers was defined as a horizontal band for which any boundaries between the inner nuclear layer, outer plexiform layer, inner plexiform layer cannot be identified. And coming to results, 51 eyes of 35 patients were included in group 1, that is turbid cyst group, and 50 eyes of 35 patients were included in group 2, that is non-turbid group. And the grades of diabetic retinopathy, moderate NPDR was a most common type of retinopathy noted. And comorbidity distribution of enrolled patients, hypertension was 57%. And distribution of hypertension in both the groups, it noted higher percentage in turbid cyst group than non-turbid cyst group. And chronic kidney disease also was higher in turbid cyst group. We noted dyslipidemia, almost the same percentage in both the groups. And HbA1c is also more in turbid cyst group with significant p-value. And central foveal thickness was also more in turbid cyst group. And other parameters like drill and hyperreflective foci were around 55% in both the, in group 1 with significant p-value. And coming to discussion, we observed individuals with turbid cyst had poorer glycemic control, longer duration of diabetes mellitus, presence of hypertension, chronic kidney disease as comorbidity compared to patients without turbid cyst, and poorer vision also. And we studied 51 eyes of 35 patients with turbid cyst, and we found association with hypertension, CKD, and no association with dyslipidemia. And OCT parameters were also more in turbid cyst group. And similar study conducted by Ramesh et al., they also noted these OCT parameters were more in turbid cyst group, and they found no association of systemic conditions like hypertension, renal, or cardiac disease. And study by Haute-Couture et al., they noted severe NPDR is the most common form, and we found moderate NPDR is the most common retinopathy noted. And study conducted by Aarti et al., they studied 131 eyes of 91 patients with DME and observed higher prevalence of hypertension and lower serum triglycerides in group with more hyperreflective foci. And take-home message, turbid cysts are commonly observed in patients who have concurrent conditions such as nephropathy and systemic hypertension, and they often indicate a poor visual prognosis for patients as they are frequently associated with presence of disorganization of inner retinal layers, which is an ischemic marker. And the presence of hyperreflective foci is an inflammatory marker, such as corticosteroids may be more effective treatment option than anti-VEGF, and this finding could potentially lead to modification in the treatment approach. These are my references. Thank you.
You said moderate NPDR, but you found a lot of CKD. Did you by any chance miss PDR? Because CKD is not so common in moderate NPDR as compared to PDR. The second thing, your conclusions are not, you said duration. I don't think you talked about duration of these patients of diabetes. How long was the diabetes? You didn't say, but you concluded that duration was a cause. Did you say?
In the slide, it was not there.
Then how can you conclude, give a conclusion like that? The last conclusion, just put that conclusion slide. Yeah, again, inflammatory marker in a turbid cyst, that corticosteroid. Did you conclude that the inflammatory marker is more in that?
Because hyperreflective foci was more in the turbid cyst.
Inside the cyst?
Inside. Not inside the cyst. overall in tuberculosis group, hyperproliferative foci was more.
No, but that is because the disease is more advanced in that. You're saying hypertension and everything is there in overall systemic. So, sort of other factors are coming into this. It's not just the turbidity is not really may not be related to inflammation. Too many factors. So this may not be the way to go about it, like just doing percentages. Then you have to do some multivariate analysis for.
Nice study, but what madam is trying to say is that from what you presented, you might have to maybe analyze it differently to come to this conclusion. From what you have said, this conclusion may not be absolutely valid.
We haven't studied the treatment approach.
Correct. Exactly.
Thank you.
Okay, the next presentation by Dr.
Good morning, everyone. My paper is on IgG4 related ophthalmic disease, an observational case series from a tertiary eye center in Kerala. IgG4 related disease is an idiopathic multi-organ inflammatory state. Manifests as chronic relapsing sclerosing inflammation in any organ system. Pathogenesis is thought to revolve around humoral and cell-mediated immunity. Pancreas and salivary glands are the most commonly affected organs, and ophthalmic manifestations of IgG4 related disease can be varied, most commonly affecting the lacrimal gland. The aim of the study was to characterize the ophthalmic manifestations of IgG4 related disease and to study the disease response. It is a retrospective case series done at a tertiary eye center in Kerala. 5 patients were studied in a span of 2 years, and all patients who presented with IgG4 related ophthalmic disease were included in the study. A detailed clinical history was taken, uncorrected and miscorrected visual acuity and extraocular movements recorded, slit lamp examination and fundus examination done, and IOP readings recorded. A detailed examination of the orbit done, magnetic resonance imaging was done in all patients, incisional or excisional biopsy taken and sent for histopathology and immunohistochemistry tests, and biochemical tests were also done. And patients who were positive for IgG4 related disease were sent for rheumatology consultation and were started on oral steroids and immunosuppressants after ruling out a systemic disease. Moving on to the results and discussion. General characteristics: out of 5 patients studied, 4 were female, and the mean age at presentation was 40.2 plus or minus 15.43 years. The presenting complaints were prominence of eye in 80%, lid edema in 40%, and double vision in 60%. In our study, only 1 patient had bilateral presentation, and only 1 patient had visual acuity impairment. Lacrimal gland was the most commonly affected organ, followed by extraocular muscles and soft tissue. And none of our patients had extraorbital manifestations. Serum IgG4 was done in 4 patients and was found to be raised in all the 4. And C anchor was positive in 1 patient, CRP was raised in 1 patient, and serum ACE was raised in 1 patient. And there was rapid progression of signs in 1 patient, resulting in profound visual acuity impairment. Radiological imaging showed involvement of the lacrimal gland, extraocular muscles, soft tissue, and lacrimal sac. Figure A is a T2 weighted MRI showing a solid mass in the right inframedial quadrant of the right orbit with involvement of the extraocular muscles and lacrimal sac. And figure B is a T1 weighted MRI showing a solid enhancing lesion in the inframedial part of the right orbit with involvement of the inferior rectus and the medial rectus. Incisional or excisional biopsy were done and sent for histopathology examination. Histopathology evaluation was available in all the patients, and the most prominent features were storiform fibrosis, lymphoplasmacytic infiltration, eosinophilic infiltrate, and perivascular inflammation. Immunohistochemistry for IgG4 positive plasma cells was performed in all cases and were consistent with IgG4 related disease. CD3 and CD20 markers were also positive. And according to the diagnostic criteria for immunoglobulin G4 related ophthalmic disease, 4 patients were classified into the definite IgG4 related ophthalmic disease category and 1 patient into the probable category. Treatment was started with oral prednisolone, mycophenolate mofetil, azathioprine, and methotrexate. The mean follow-up period is 9.4 months, and only 1 out of the 5 patients were found to have recurrence. IgG4 related orbital inflammation. The most common presentation is the painless eyelid or periocular swelling and proptosis. Order of involvement is lacrimal gland, followed by orbital soft tissue, extraocular muscles, eyelid, optic nerve, and fifth nerve. Inflammation and fibrosis are the key components in pathogenesis, and patients with IgG4 related orbital inflammation are at an increased risk for lymphoma. The various treatment modalities available are oral steroids are the first line of management, intraorbital corticosteroids, immunosuppressive agents like azathioprine, methotrexate, and mycophenolate mofetil, rituximab, which is a monoclonal antibody against CD20, is a promising treatment modality now. This is a comparison of various studies. In a study by Michael Lebo et al., 19 patients were studied in a span of 8 years, and 57.9% were found to have bilateral disease. Lacrimal gland was the most commonly affected organ. Serum IgG4 was elevated in 61.1%, and systemic disease was found to be present in 78.9%, and 66.7% had disease relapse. In a study by Sato et al., 21 patients were studied in a span of 16 years, and 57% were found to have bilateral disease. 10 out of 13 people tested for serum IgG4 were found to have elevated serum IgG4, and 29% had systemic IgG4 disease, and 28% had relapse. In a study by Takahira et al., 7 years, 16 patients were studied. Lacrimal gland was the most commonly affected organ, and 93.75% had elevated serum IgG4, and 87.5% had systemic disease. The results were consistent in our study. So what we knew before the study was the characteristics of orbital inflammatory diseases, and what we wanted to know was the characteristics of IgG4 related ophthalmic disease, variable presentations, treatment and response. And what we learned with the study was IgG4 related ophthalmic disease is an orbital painless subset of orbital inflammation. HPV is crucial in correct diagnosis. Long-term follow-up is required, and prompt and accurate diagnosis ensures a good prognosis. These are my references. Thank you. No, so all of these patients were diagnosed in our department, and we sent them for a rheumatology consultation, and systemic disease was ruled out and started on medications. No, madam. Actually, when the first patient presented, there was a confusion, and after it was found to be IgG4, now we keep this as a differential while a patient with a chronic sclerosing disease come. Now we keep this as a differential and do IgG4.
So when do you do it?
So when there is actually 2 of our patients presented as a painless swelling, like painless proptosis, and with imaging we found it to be a lacrimal gland enlargement. So we did a biopsy and found out immunohistochemistry and HPV.
So it's a gray area, because even the idiopathic inflammation of the orbit can also involve all the structures that you said. What was very noteworthy or surprising was that in your study, 80% had a extraocular muscle involvement, while the other studies which you have projected, they are only 30 or 34%. So that's something which tells you that either there is the correct. Were there any? Did you come across any other studies from India on IgG4?
No,
So,
sir.
correct.
Yeah, only one patient had bilateral. No, madam.
We're trying to do, it's a very nice study, very good thought. What we are trying to extract out of this is that did you find anything which you can tell everybody saying, oh, if you find these 2 3 things, first think of IgG4 and get it done before you move.
The main thing is a painless, like fibrosing type of inflammation, which is usually presented as a periocular swelling. And actually, one of our patient was like presented with a bilateral lid edema. For many years, she was being treated at a hospital. And once it started becoming a swelling, like we suspected this, and we sent for an investigation. And then we took a biopsy, and it was consistent with our IgG4 related disease. Thank you, ma'am.
Yeah. Good morning. My topic is assessment of the choroidal thickness in the pachychoroid disease spectrum. So, pachychoroid disease spectrum are a group of clinical entities that are characterized by thickened and hyperpermeable outer choroidal vessel layer, which is the hallux layer. The average choroidal thickness is around 260 micrometers, the highest being at the level of the macula. And the spectrum includes the following entities, that is the pachychoroid pigment epitheliopathy, central serous chorioretinopathy, pachychoroid neovasculopathy, polypoidal choroidal vasculopathy, and the newly added entities peripapillary pachychoroid spectrum and the focal choroidal excavation. The aim of our study was to analyze the choroidal thickness among the patients of pachychoroid disease spectrum and to evaluate their choroidal vascular morphology. So, we conducted a retrospective study at a tertiary eye institute in South India. In our study, we took the EDI OCT of 79 eyes of 45 patients who were already diagnosed to have a pachychoroid in our retina clinic, and it was analyzed for the choroidal thickness and the choroidal vascular morphology. The choroidal thickness was measured in the central 3000 micrometer cut section using the calipers tool by taking the average of 3 points at the level of the central macula. In the same section, we studied the choroidal vascular morphology that included the number of pachyvessels which were manually counted, as well as the mean pachyvessel diameter that was also measured using the calipers tool. So our results were as follows. 76% of the study population showed a bilateral presentation, that is in among 34 patients. Among the various entities studied, uncomplicated pachychoroid was more common than the pachychoroid disease spectrum. And uncomplicated pachychoroid were characterized by thickened choroid and the presence of pachyvessels, but there was no retinal alterations. Among the pachychoroid disease spectrum, central serous chorioretinopathy was the most common. A male preponderance was observed. So the age of presentation varied among the various entities we studied, with central serous retinopathy presenting at a younger age, average of 39.5 years, and uncomplicated pachychoroid, pachychoroid pigment epitheliopathy, and peripapillary pachychoroid spectrum presented in the older age. The choroidal thickness ranged from 350 to 400 micrometers, the average of 387.88 micrometers, and the maximum choroidal thickness was observed in polypoidal choroidal vasculopathy, followed by pigment epitheliopathy and central serous chorioretinopathy. On evaluation of the choroidal vascular morphology, we observed that the average number of pachyvessels were more in the pigment epitheliopathy, followed by pachychoroid neovasculopathy and the polypoidal choroidal vasculopathy. And mean pachyvessel diameter was observed to be larger in the polypoidal choroidal vasculopathy, followed by pigment epitheliopathy and central serous retinopathy. So the results that we observed in the mean pachyvessel diameter was similar to the results we got in the mean choroidal thickness. In our study, among the pachychoroid disease spectrum, central serous retinopathy was the most common and the least common was pachychoroid neovasculopathy. So our finding was similar to a study conducted by Dansingani et al. Central serous retinopathy presented at a younger age, whereas pachychoroid pigment epitheliopathy presented in the older age group. However, a study conducted by Rosa Dola Marco et al. Showed that both central serous retinopathy and pigment epitheliopathy presented at a younger age. The average choroidal thickness was 387.18 micrometers, the highest being in the polypoidal choroidal vasculopathy that was also observed to have a large mean pachyvessel diameter. And a study conducted by Veronica Castro Navarro et al. Showed that it was the presence of dilated choroidal vessels which was a defining criterion for pachychoroid. However, the average number of pachyvessels were observed to be more in the pigment epitheliopathy. So though the number of pachyvessels are more in pigment epitheliopathy, the choroidal thickness and the mean pachyvessel diameter were observed to be more in polypoidal choroidal vasculopathy. Hence, we were able to conclude that the severity of a pachychoroid disease spectrum is predominantly determined by the pachyvessel diameter and the choroidal thickness rather than the number of pachyvessels. And we also suggest that patients with uncomplicated pachychoroid and large vessel morphology be followed up more frequently to look for any progression to the pachychoroid disease spectrum. These are my references. Thank you.
What's your inclusion criteria?
Ma'am, any choroid thickness more than 300 micrometers who were already diagnosed to have a pachychoroid in the retina clinic.
So what exactly was your question?
Ma'am,
What exactly was your research question?
Aim was to analyze the choroidal thickness so that we can see,
But you have already
diagnose.
decided that the choroidal thickness should be this high before
Yes,
you
ma'am.
take these patients. So what was your question?
So we could also see the progression, whether the disease is going to
Did you
progress.
look for
by-
progression or was it a 1 month study?
It was
Yes.
a May to July only we conducted the study.
1 or
so
2
we
month
need to-
study. So
yes,
how
ma'am.
much time did you get for progression? And you these different diseases had different group numbers.
Yes,
How
ma'am.
are you going to correlate the group with like that? I mean, you had more of uncomplicated pachy.
Yes,
I don't know what you mean by uncomplicated. Means just thickness was there.
They have a thick choroid and they have pachy vessels, but there is no other retinal pathology, no alternation. So, no clinical,
no change on OCT or
only the OCT
So
finding.
you have actually, I'm not very sure what exactly was your research. It's not clear at least what you have tried to look for. And so when your question is not correct, I don't think your conclusion could be. Because in that case, you'll have to compare these equal groups. I mean, that's my
It's right. No, can you answer the question? How you correlated the choroidal thickness?
Study. Sir, we need to follow up these patients again with OCT, analyze the choroidal thickness. In the, yes. Aim. Mm. Yes. Caliper tool in the OCT. I did it myself. Yes, sir. Okay. Thank you, sir.
Good morning all. I am going to present paper on choroidal vascular and morphometric changes after intravitreal aflibercept injection in polypoidal choroidal vasculopathy. Coming to introduction, polypoidal choroidal vasculopathy is one of the commonest exudative maculopathy that we see in our day-to-day practice. Our diagnosis is mainly based on typical clinical findings including reddish-orange subretinal nodule and subretinal hemorrhage. OCT findings suggestive of PCV are thumb-like elevation of the retinal pigment epithelium, notched PED and double layer sign. Diagnosis is mainly confirmed by ICGA findings like nodular hyperfluorescence, branching vascular network of inner choroidal vessels and hypofluorescent halo. Aflibercept is a newer anti-VEGF molecule which act against both VEGFR1 and VEGFR2. Coming to management of PCV, treatment response of PCV is currently based on demonstration of intraretinal fluid or subretinal fluid reduction on OCT and obliteration of polyps on ICGA. But as ICGA is an invasive procedure, it is not universally available. Recently, new choroidal indices like subfoveal choroidal thickness and choroidal vascularity index have been described by various authors. Study of these changes in these indices after treatment would be a surrogate for assessing the treatment response. Coming to aim of our study, to investigate changes in subfoveal choroidal thickness and choroidal vascularity index after intravitreal aflibercept injection for PCV. Coming to materials and methods, it was a retrospective study. Study was conducted in a tertiary eye institute in South India. Study period was January 2023 to July 2023. Study subjects were 34 eyes of 33 patients. ICGA diagnosed PCV eyes were included in our study. We have used OCT on Heidelberg spectralis, spectral domain OCT. Loading dose of aflibercept, standard dose was given. Choroidal changes analyzed at baseline and after 3 injections. Monthly 3 injections were given and 1 month after injection we have again analyzed subfoveal choroidal thickness and choroidal vascularity index. Now how to measure subfoveal choroidal thickness. For measuring subfoveal choroidal thickness we have used caliper tool, and using caliper tool vertical distance was measured from hyperreflective layer of retinal pigment epithelium to reflective layer of choroidoscleral interface. Now, how to measure choroidal vascularity index? For measuring choroidal vascularity index, we have used a newer software known as ImageJ software. First of all, we have exported the original OCT image into ImageJ software. Then we have used an algorithm known as NIBLAC algorithm. Using Nyblak algorithm, we have binarized the original OCT image. Then we obtained an 8-bit image. Thus obtained 8-bit image was seen in this picture. Binarized image is image in which we can see dark and white areas, and the dark areas represents the luminal area and the white areas represent the stromal area. Then using the image software itself, we have analyzed the image, and we obtained stromal choroidal area. Then 100 minus stromal choroidal area, we will get the luminal choroidal area. Actually, choroidal vascularity index is total luminal area by total choroidal area. Coming to results of our study, majority of the patient in our study group were male, and most of the patient in our study group came in the age group of 71 to 80 years. Most of the patient had one-line improvement. In our study, there was a reduction of subfoveal choroidal thickness from 388.9 to 333.1, which was statistically significant. In our study, we have also obtained reduction of choroidal vascularity index from 63.1 to 61.8, which was also statistically significant. When we are discussing about subfoveal choroidal thickness, previous reports demonstrated that subfoveal choroidal thickness decreases significantly after intravitreal injections of ranibizumab and aflibercept, while others did not find any significant change after bevacizumab and ranibizumab. However, our study found a significant reduction of subfoveal choroidal thickness after 3 months of treatment of aflibercept. When we're discussing about choroidal vascularity index, studies have shown that aflibercept in comparison to ranibizumab decreased choroidal vascularity index better in neovascular AMD, but these studies have excluded PCV. Our study found that PCVIs also demonstrated reduction of choroidal vascularity index after aflibercept therapy. There is not enough literature in PCVIs treated with aflibercept. Though it was observed that aflibercept was a better agent than ranibizumab in PCVI in terms of vision gains and retinal drying, demonstration of choroidal vascular changes have been inadequate in previous studies. Our study demonstrated that aflibercept decreases choroidal thickness in these pachychoroid eyes by decreasing the dilated choroidal vessels and thereby reducing the intraretinal fluid, subretinal fluid, and sub-RPE fluid in these patients. When we compare choroidal vascularity index with subfoveal choroidal thickness, choroidal vascularity index is a better parameter because it is not influenced by age, axial length, IOP, and time of day. Coming to conclusion, response to aflibercept in PCVIs could be gauged by non-invasive imaging like change in choroidal thickness and change in choroidal vascularity index. Choroidal thickness in PCVI significantly decreased after intravitreal aflibercept injection. Aflibercept treatment also showed decreased choroidal vascularity index changes. These are my references. Thank you. To measure the central choroidal thickness change after aflibercept injection, we have analyzed the central choroidal thickness and choroidal vascularity index. Monthly 3 injections were given, and baseline investigations done, and after that we have given 3 monthly injections, and 1 month after injection we have again analyzed OCT changes. All patients we have equal number of injections were given to all patients. 3 injections were given.
Baseline index before you started these patients, and then like all of them were similar kind of patients, or some of them had more? Was there any matching that way?
Baseline as a baseline, we have fundus examination were done, OCT taken, and subfoveal choroidal thickness. Before injection, we have also taken the subfoveal choroidal thickness and choroidal vascularity index. ICGA was done.
No, all of them were showing some bleeding at the central state. This thing probably, no?
Yes.
All of why did you do this injections? Because IPCV was having some complications in the retina, I suppose.
Yes.
Yes or no?
Yes.
So what was that? If there was blood there, that thickness would be also affected. None of these patients had retinal thickness increase, only choroidal.
Some of the patients had retinal thickening improvement also.
No, what I'm
Uh,
yeah, because if there is blood there, this thing will not be the imaging which you're talking about. You will not get. So how will you assess? So if there was no blood, then why did you inject? That was my question.
uh,
Don't worry. We know it's not. Just asking you because I am a little interested in your software, but
retinal thickening was increased in some of the patients. And
did you get this beautiful image which you showed?
we have analyzed the some of the patients had increased retinal thickening. In that patients, we have analyzed the subfoveal choroidal area of 3000 micrometer from the using the caliper tool, and using the polygon tool, we have marked 3000 micrometer area of that lesion only. Then using the software, we have calculated the stromal area. In choroidal vascularity index is the value. Yes, pre and post. Thank you.
So, good morning, all. My paper for today is on knowledge, attitude, and practice pattern among ICU nurses on eye care practices in ICU patients. Here are the contents. Eye care forms a major part of care provided to all patients in ICUs. Critical care nurses have limited knowledge about the anatomy and physiology of eyes, and ocular manifestations in critically ill patients may lead to a delay in the identification and delivery of proper eye care. My objective is to estimate the knowledge, attitude, and practice pattern of nurses regarding the eye care in patients admitted in the ICU in a tertiary care center. A descriptive study was done among ICU nursing staffs using a well-structured questionnaire. A total of 74 nurses were included in my study. Participants' age, education, gender, experience in critical care, type of ICU, and previous eye care training was noted. Data was collected in the form of a questionnaire. It had 3 parts: knowledge, attitude, and practice, with 7 questions in each section. The questions on knowledge assessment were on different ocular signs in the patients, their risk factors, and management with 2 or more correct response. A score of 3, 2, 1, and 0 was given respectively, and the participants were grouped into based on their score into 3 parts: good, average, and poor. Now, questions on attitude were based on the importance of early detection and treatment and prevention of eye disease. Positive response is given a score 1, and negative response is a score 0. Depending on the total score, attitude was again graded into good, average, and poor. Practice was based on the technique and method of eye care practiced by the nurses in the ICU, and again, based on the scores of practice pattern, was again graded into good, average, and poor. Statistical analysis was done. Now, moving on to the results. 74 nurses, ICU nurses, were included in my study. The mean age was 33.7 years. 92% were females, 93% were BSc graduates, and 35% underwent eye care training. 54% had 1 to 5 years experience in the ICU, and 20.3% were from the neurosurgical ICU. 78.3% of the participants had an average knowledge, and most of the participants answered saying that ICU patients were at a higher risk for exposure keratopathy. That's, as you can see in the bar diagram, it's 86.48%. And least knowledge was for the question on reasons for developing exposure keratopathy. That is 54%. 50% of the participants in my study had good attitude. Out of the 7 questions under attitude, maximum positive response was for the question on the effective care of eye care in preventing eye disorders, and least response was for the question on what will be done on seeing a patient with incomplete eye closure. There was no significant correlation between knowledge and attitude score, and the majority of the participants had an average practice pattern. Maximum response was the question for on last assessment of lid closure, and least response is for the question on the method of cleaning the eyes of the ICU patients. 66% of the participants assessed the eyelid closure in their last duty. 59.5% of the participants assessed eyelid closure hourly, and 37% instilled eye drops 3 hourly and 6 hourly respectively. And 41.9% responded that they used distilled water to clean the eyes of the ICU patients. 50% of the participants cleaned the eyes hourly. 60% performed lid taping for incomplete eyelid closure. And 60.8% of the participants followed a fixed protocol, of which 28.4% of the participants said that they got the protocol from their seniors or colleagues. Then moving on to the discussion. 93% of the participants were BSc graduates, 35 have undergone night training. Majority of the participants had an average knowledge. 50% of the participants in my study had good attitude, and majority were having an average practice pattern. So in our study, we observed that both participants with good and average knowledge showed a good attitude and an average practice pattern, and there was no correlation between knowledge and attitude. Similar to our study was another study by Khalil and et al. In contrast to our study, a study by Mariam et al. Showed a positive correlation with good knowledge and attitude. And a study by Ebedi et al. Showed that the study participants had limited knowledge, but showed a positive correlation to attitude. Majority of the staffs assessed the eyelid closure in their patients in their last duty, and 60% performed lid taping for incomplete lid closure, similar to a study by Aditi et al. In a study by Sonal et al., less than quarter nurses responded that they were unaware of the high potential of exposure keratopathy. And only 50% of the nurses checked the eyelid closure and took steps to prevent the exposure keratopathy. And an awareness protocol coupled with awareness programs can improve the knowledge. Now, post my study, we had conducted an awareness class to improve the poor knowledge and attitude. So here is our new protocol that we brought up. It had grade 0, 1, and 2 based on their, which was and then treated based on this grading. Treatment was done based on the grading. And to conclude, ocular complications occur in a large number of ICU patients due to lack of awareness, which leads to a delay in the identification and management. A clear protocol can improve the quality of the eye care in our staffs. Here are my few references. Thank you. Ma'am. Yes. Ma'am, we had given them a score we had given one score for positive response, and if they didn't do the right didn't do that, we gave them a score 0. Just 1 and 2 was the scoring for that. 1 and 0. Attitude. Ma'am, attitude was we checked on how were they doing that particular, like, for effective eye care on preventing disorders. How did they do? Was it high? Was it moderate? Or was it low? We graded based on that. If it is high and very high, we gave them a score 1. If it is moderate, yeah, ma'am. Attitude. How would they would? Yeah, ma'am. How attitude, ma'am. Towards, ma'am. Yes, ma'am. Yeah, ma'am. Yes, sir. Yes, sir. We do have. Okay. Yeah. The question is not this. I just it is. Answer. This is the question. Yes, sir. If it's yes or no, yes, sir. And for yes or no, and if it's high and very high, we get them a score 1. And if it is moderate or low, we get them a score 0, based on their attitude. How did they treat the patients? Yes, sir. We did conduct a awareness class, and we did introduce our protocol, sir, ma'am. Staffs, ma'am. Diploma, yes, sir. BSc staffs were, and higher, and there were more BSc nursing staffs as well, and who had more experience. They practiced the protocol more than the rest of them. Thank you.
See, every competitive free paper session, you will generally hear judges saying that it was very difficult to assess. It has become a cliche, but it's a fact here. I mean, all of you, of course, when we ask questions, you might feel that the candidate didn't do well, but it was only to bring out the impact from your study and also to bring out how much you understood what you were doing and how you can implement it when you grow as a faculty in your practice. But all of you did extremely well. The questions, the study, the level of involvement was excellent. So congratulations to all of you.
Just like to put that none of our questions are meant to discourage you, just to show you what is important. I mean, your research question, your observations, and your conclusions should be put together. We all know that you are just doing a study, and that is part of your thing. You will be learning, but remember, those conclusions have to correlate with your research question. You are finding out something, so we need to know the answer to that question. So it should come out like that. That's all. Otherwise, all of you have done well. And congratulations and best wishes. You reached the final. That itself is a very good part.
So actually, it is for you to learn how to do a scientific study. So when you do a thesis, it is not the results you is not important. You learn how to do a scientific study. Those things you should continue in your profession later.